Debra and I think, will be mainly focusing on Tyvaso, which is an inhaled therapy given through a nebulizer, which we've diagrammed on to the left in the picture. It's a machine that's about the size of this water pitcher. Looks almost kind of like a teapot. It's
it's small.
Do you have yours with you?
Yeah.
Right.
So the patients that I have, I've had one or two patients that have discontinued it when they saw it and saw some of the steps that are involved in cleaning it and assembling it. But the majority of patients that have been on it have really found it to be beneficial for their quality of life. And the Tyvaso is administered 4 times a day. Generally takes about 2 or 3 minutes to get the treatments. We generally start off with 4 breaths 4 times a day, and each center has a different titration protocol for increasing the dose. And my center, typically we increase by 1 breath per week unless symptoms develop, side effects develop. So I'll turn the mic over to Debra.
Hi. I would like to echo most of the doctor's sentiments in terms of Tyvaso. I too use it, and we use it in our facility. Currently, I only have 1 patient that's on the Ventavis. That's been tried and true, but kind of moved out of favor in some respects, at least at our center. The patient that I do have on Ventavis is doing extremely well with it, and probably will stay on that. Tyvaso, I've had handful of patients, roughly 5 patients. There have been a couple that I've had to transition off for various reasons. One of the bigger reasons is due to mouth soreness, and what we have found, if you don't place, and you can correct me if I'm wrong, if you don't place that mouthpiece back far enough, the medication gets in your mouth, and if you don't rinse and spit, it can cause irritation. And I just said the key there: to prevent the irritation, rinse your mouth and spit after you use it, okay? Because that mouthpiece should act almost as a tongue depressor on the back of your tongue so the breath gets in. As the doctor stated, typically 4 breaths 4 times a day, with a goal, loosely a goal of 9 breaths 4 times a day, but we have been able to go up to 12 breaths in some patients with recent approval, or up to 14 breaths. And again, that titration varies on the patient and how they're responding to the medication, how they feel on the medication, side effects, are they tolerable? The typical side effects, like all prostacyclin therapies, nausea, a little bit lesser with the inhaled therapies, but you can have some nausea, dyspepsia, some diarrhea, oral pain, discomfort, but the biggest one is the cough. And again, to try and avoid the cough, rinse and spit after you use it. And you can also back down on the amount of breaths that you're taking. Sometimes that will help as well. So we have 1 person on inhaled. Can I ask, I'm assuming it's Tyvaso? Are you comfortable sharing your story about it, or?
I started on the Tyvaso at the beginning of the year. I had been on UpSummit, and it didn't seem to be having the positive effects that we were hoping for. And so they added the Tyvaso, and but we started at 3 breaths.
Okay.
And increased it by 3 every couple of weeks. So I've been on 9 breaths for, well, at least 3 months. But I have a friend who is the leader of our support group, and she's also on it, and doesn't seem to have any issues with it, but she's on 15 breaths.
Oh, wow.
But she does it every 3 hours. And I was told not to do it any more frequently than 4 hours. So, you know, you wonder, you hear so many things that you always have to sort out, you know, what's accurate and what's kind of been pushed a little. One of the reasons I came to this session was because since I've been taking it, the cough definitely is the biggest issue. And when I finish taking the 9 breaths, I feel like I'm going to cough my lungs out. It's just I gag and dry heave and just cough. And the nurse that had come from the specialty pharmacy to bring all of the equipment had said, make sure that you rinse your mouth out. Don't keep any of the medication in your mouth after. So I was kind of prepared for that, but I kind of wasn't prepared for the upheaval that takes place at the end. And so I've been trying to find other people who might have other tricks of the trade, so to speak.
Sometimes a cough drop can help, but I don't want you to rely on a cough drop either. You might want to talk to your provider and see, maybe if you're on the 9 breaths, if it would be reasonable to back down and then kind of gradually bring you up. I defer that to your provider.
I've tried drinking something hot, drinking something cold, cough drops, lozenges.
Sometimes the thing that helps is to back off on the dose for a little while. And if you tell your provider, your physician, that you're having a lot of trouble, sometimes that will work for my patients. We back off for a few weeks or even 3 weeks and then go back up a little bit at a time, and sometimes that can help. Cough is a problem with it, but I think that over time it can be managed. But they need to know that you're coughing that much. I would not want you coughing you that much if you were my patient. So, I would make sure they know about it.
I could deal with the inconvenience because it is, as you said, I think initially some people might find it daunting because putting everything together every day, washing it every day, and making all the pieces fit.
And that's so important, though, that you do that.
Right, and the second day I had it, I thought, oh, this is a piece of cake, I can do this. And I started putting all the pieces together, and then I started breathing, and I thought, oh, I don't see any smoke in there, because when you inhale, there's kind of a mist. Well, I'd forgotten to put the medication in the cup, and so I was breathing nothing. And so you learn day by day not to do that again, but it is, and then carrying it, bringing it on the plane and bringing it if I go shopping or if I go to a lecture. It does have its drawbacks. It's certainly not taking a pill. And I guess, if you get positive effects from it, then it kind of makes that all worthwhile.
Absolutely.
But I'm kind of not at that point
They're
yet.
kind of small victories, and that's how you have to look at it, that you didn't put the medication in at once, that you learned from that. The next time you did, there's your small victory for the day, and you build on that.
Exactly.
But I guess one of the things we ought to talk about, we haven't really touched on, is why inhale prostacyclins, okay?
Yes.
Because prostacyclins, we believe, are one of the best medicines for patients with pulmonary hypertension. We know that for our sickest patients, we give them IV form of the drug, and that has the greatest effect. And prostacyclins have been the only drug that's ever shown improved survival of patients with pulmonary hypertension, but the IV form is very hard to give. And the first drug that was available was iloprost or Ventavis, which was a drug that was developed in Europe. I think it's the only drug that's never had a U.S. trial because the data was so good from Germany. And it is a little blue box about this big, and I started with it because that's what we had to begin with, and we had a lot of experience with it. But it's a very smart little machine. You put the medicine in, and it records when you took the medicine, how long it took to get the treatment in, and whether you had any errors during it, and the data will go back 5 years. And so we would have the patients come in, and you show them how to do it, and every time they came to clinic, we would download it, and we would see what they were doing. And I'd have a patient come, "Doctor, it's not helping me any." And I said, "Well, it's because," he says, "I'm taking all my treatments." I said, "Yeah, you took 6 in the parking lot right before you came in." But I think for inhaled drugs, getting them into the body with less side effects, even the oral prostacyclin pills now have a lot of side effects, and the inhaled drugs don't seem to be as much because you can get a good dose to the target area in your lungs very easily, and I think that's one incentive for it. But what I tell my patients is, if you're going to Walmart do your treatment in the car, because these drugs work right away and you can see an improvement. And all the studies with these drugs show that the cardiac output goes up and the pulmonary pressures go down, and so you can do a little bit more if you associate with exercise. And I know if you get there and you can walk down the aisle, you're going to want to take it again next time you're doing something. So you really have to associate it with activity, because you can get more activity out of your body if you use these drugs appropriately. Unfortunately, with Ventavis, you have to take it 6 to 9 times a day, and those treatments take about 3 to 5 minutes. Now, when we started, before we made improvements, the treatments were taking 12 or 14 treatments 6 times a day. And the screens had to be boiled once a day. So it was very complicated. And I think that we've seen over time, patients find it easier to go to the Tyvaso because it's a little easier to manage. I think you had a question, and oh, they're going to record it, so we'll let you talk to the mic.
I'm from Canada, and we don't have inhaled therapies in Canada. So can you just basically literally start from scratch and tell me what it is, like how it's used, what the whole process is, and why in Canada we have 9 approved therapies, and we generally start with the Adcircas and the Tracleers, and then if you need it, you move to the only other one we have that is a prostacyclin or whatever it's called is the IV therapies. Uptravi's just been approved, but it has by Health Canada, but it's not available yet through the provinces. So where on the spectrum of medicines do inhaled therapies fall? And I'm just wondering why we don't have them available in Canada.
So the inhaled therapies are indicated for patients with functional class 3 or 4 symptoms, meaning symptoms with less than ordinary activity, symptoms at rest, and they're typically used as add-on therapies rather than upfront medicines.
But actually, Ventavis is approved for 3 and 4. Tyvaso is only approved for 3, functional class 3, so not the sickest patients. And it's really because the way that trials were done. And different countries have different medications available. A lot of governments who are paying for medication don't want to pay certain prices. In the US, there are 14 drugs available. But the cost is ridiculous. And the inhaled therapies are some of the most expensive therapies that there are. And before there was only IV and inhaled, people went with inhaled because it was cheaper, but they are very, very expensive. Up to the point of $120,000 to $140,000. Used to be about $80,000, but it keeps going up.
$170,000 for the Tyvaso, $170,000.
It just keeps going up, though.
Right, but Uptravi's going to be the same thing. That's really the cost of what Uptravi is going to be. But so, having said that, like, how does the process work? Like, you talk about having to clean it every day. Like, what is and there's a lot of, if you use an infused therapy, there's a lot of work.
Yes.
Mixing all of your medicines.
Even more work.
Right, exactly. So this is in the States is an inhaled therapy kind of used first, because even though there's a lot more work to it, it's less work than an infused therapy, or it's just, again, a doctor's recommendation?
I think in the past it's been because the risks are less with inhaled therapy.
Okay.
When you have IV therapy, there's the risk of infection from the line and interruption of the line that can cause very serious problems. But the inhaled therapies, interruption is not as dangerous, and the side effects, you're not going to get an infection that's going to put you in the hospital. You're not going to have those problems. And it was to try to prevent people from going on to IV therapy.
Oh.
And I think that is a very good thing. But you ask a really good question that we don't know the answer to. Now in the U.S. we have 14 drugs. Where do our oral prostacyclin fits in? Where do our inhaled drugs fit in? And we have studies that show upfront combination is good, but we have people on single drugs that have been doing well for years. So we're at a point in our lives, I think, that we are not 100% sure where we need to go with inhaled or oral, but we're going to work that out over time. A lot has to do with the experience of the person you're seeing and their patients and what their patients can do. We also have to deal with payers and what they're willing to do.
Right.
So we don't know everything about this that we like, and we don't know which things are better at this point, because you can't compare trial to trial. This trial was done in these patients at this time. Well, that was 10 years ago or 15 years ago, and now we have a new trial that's out, and medicine has changed a lot since then. So we don't have a good answer. But there are countries in South America that only have one drug approved. And that is really tough. But I think the Pulmonary Hypertension Association and a lot of these pharma companies are working with these countries to try to get reasonably priced drugs into their countries. So like in Mexico, they don't have a lot of money for drugs, so what you see in that country is a lot of patients have what's called atrial septostopy, where they make a hole in the upper part of the heart to relieve the pressure. And they have a huge experience down there because they don't have drugs. So I think that when to use inhaled is still up in the air, but as before we use any IV therapy, I think a lot of people would like to do that. I don't know what you feel.
Well, I would like to say I could only speak on behalf of our center. Typically, now I do have patients that are severe enough to actually warrant IV therapy, but for various reasons that IV therapy or subcutaneous therapy does not fit into their lifestyle. They just simply don't want a catheter or something infusing in their belly all the time. They just don't. But again, they're severe enough to warrant that. Sometimes those are the folks that I go ahead and offer the inhaled Tyvaso to them, with the caveat, we will try this. If you worsen or don't feel somewhat significantly better on this, we're going to have to revisit whether or not you go on IV or subcutaneous therapy. I have had success with the Tyvaso inhaled therapies. I've had some patients that didn't do quite so well on it and had to come off. It just depends on the individual, and it depends on your providers, what they recommend, and I would always defer to the providers that you're dealing with as to what you need. In terms of Canada, I don't have an answer. We have a hard time, even with our 14 therapies, everything goes through a prior authorization, and we do get pushed back a little bit. I can honestly say, to my knowledge, there has not been a patient that I've dealt with that has needed therapy that we have not been able to get on therapy.
We have a question over here. Can we pass the mic over?
Thanks. Hi. I have two questions. The first one, from what you were saying, it sounded like iloprost is maybe more convenient to use. I know nothing about either of these, and so I was wondering why it is that you tend to prefer to prescribe Tyvaso rather than iloprost.
Iloprost is not more convenient to use.
Okay.
It's a lot more complicated, but it does help us as a clinician know when patients are taking it. We can see when they took it and how long, but it's a lot of work is to get the treatment times down. We have been in a lot of trials to try to lower that treatment time. Like I said, when we first started, it was 12 to 14 minutes, but we'd have patients come to clinic and we could see their treatment times were 18 minutes. And that's way, way too long. And so we would work with them because you have to hold it exactly level and you have to breathe. It's not, you can't read the paper or anything like that. I'd say to the patient, you're reading the paper, right? And they weren't getting medication. But then they increased the concentration, so now the treatments are 3 minutes, 4 minutes, and that is really good. But the maintenance of the machine, the little machine's about $7,000 that you have to put it in, and then you have to boil screens, and after a while the screens don't work, and then you have to get new screens. It's a high maintenance thing, and you have to take it 6 times a day. So most people go to Tyvaso because it's more convenient for the patient, and it's a longer half-life of the drug, and I think that's it. I used a lot of Entavus because there was no Tyvaso back then, and you know, right now I have to say that in all inhaled therapies, there's what I call inhaled fatigue, because no matter how great the patients are, and we have our patients, you know, they were using Entavus 5.6 treatments a day on average, and we had, you know, 20 or 30 patients on it, and they were really using it. But no matter how great you are over time, you just want to throw the thing out the window. You just say, I can't deal with this anymore. I just don't want to do it. I've had a couple patients say, I'm not doing it anymore, and their family says, you're a lot worse since you stopped. I'm just not going to do it. It is, you know, if you think about just taking a pill once a day is a pain and you forget it, but if you have to do something every, you know, 6 times a day, it's a nightmare. And, you know, we have to work with our patients, and as I say, trying to associate the inhaled drug with some activity because you're going to do a little bit more is the best thing because you have some positive reinforcement there. But inhaled drugs are really hard, and I predict, now my colleagues don't agree because I've talked to some of them, that inhaled drugs are going to go away over time because it's so hard on patients.
I believe that inhaled, that's just my personal bias. I think Tyvaso was a little bit of a game changer, and I think it works for some patients, but now with oral therapies on the rise, we may see a shift in thinking in the paradigm. But orals aren't without their own, the oral prostacyclins aren't without their own side effects and issues as well. And it's not to say that if somebody came in and said, you know, I'm not going to, if they're bad enough and sick enough and their echo is worse or bad enough, I'm typically not going to go with an oral or an inhaled. It's going to be an IV therapy, which is very, affects the lifestyle, and you have to, it's a huge commitment. It's a huge commitment to the therapy and the care of the line, because mishandling of the medication or mishandling of the line can be just as lethal.
And I have to say that I've had patients who had no caregiver or family member who could help with IV, and they've been on inhaled. And I had one fella, he set his alarm every 4 hours, and he took 9 to 12 treatments of Intavis a day because his family would not help him with IV. And you have to have a backup to have IV. You have to have a caregiver who's willing to participate in your care. And his family wouldn't do it. So I think it's a good thing. And sometimes with the IV, it's the risk of infection, but also the sub-Q, you get infection and it's pain associated with the site. So I think that inhale still has its place. There's certain patients who don't do as well with the orals, for sure. And I've had people who have terrible side effects from the orals, and vomiting and headache and those kind of things. So I still think for some patients there is the place for inhaled therapies, but I don't know where we're going to end up. But I'm shifting away from it right now. We're doing a study right now to switch people from Tyvaso to oral prostacyclins to see how that'll work. And we're going to follow the people, and I don't know yet. I'm not to the end of the book, so I'll have to let you know how that comes out.
Yeah, it's still...
Taking a medicine, as my colleagues had alluded to, 4 to 6 to 9 times a day can be very challenging. Just being on an antibiotic myself 3 times a day for 10 days, I can tell you how many times I missed that middle of the day dose, and that's just a 3-time-a-day medicine, very short term. So it takes someone who's very diligent to be on a medicine that's given 4 to 6 to 9 times a day. But if it helps a person breathe, I can speak on behalf of my patients that they're willing to do it. But over time, there's definitely can be fatigue from that. I do want to share one story that I had an experience. One of my patients who was on Tyvaso was admitted to the hospital and was on Tyvaso and was unconscious and was intubated and was admitted to the ICU because of respiratory distress. His lungs weren't working properly, and the staff there knew enough that Tyvaso should be continued with him, but it made the unfortunate mistake of giving it through a regular nebulizer rather than through the specific nebulizer equipment that are provided with the medication. And the patient overdosed on that as a result and got a much higher dose that could potentially be lethal. Nearly killed him, but fortunately he recovered. And so it can be your own advocate. Make sure that if you're on Tyvaso or one of the other inhaled therapies, that if you go to the emergency room or if you go to the hospital to be admitted, bring your equipment with you so the hospital knows that this cannot be administered through alternative nebulizers.
And that's a very good point. If somebody's in the hospital and they're intubated with the breathing tube and on the breathing machine, those doses of Tyvaso are going to typically be missed because there's no way to give it if the patient is on a breathing machine. So most people, Tyvaso or the inhaled therapies are not considered a monotherapy. The only drug that they're typically on some type of background therapy. Fortunately, in those scenarios in the ICU, for example, patients can have their Revatio, as now there's an IV form. So there are alternatives that they can do, but they have to be aware, wherever the hospital, the physicians, the providers have to be aware of what you're on. So it's always good to have an emergency pack that states, I take this, my medication's here, this is my dose. That's true of any of these medicines, because don't take it lightly because it's an inhaled and it's in a little nebulizer-like machine, that it's not as potent as some of the other medications, because it is. It's very potent. It can be very dangerous if mishandled.
And I think it's really important, if you go to the hospital or you think you might go to the hospital, make sure you bring your equipment, because even though we instruct the nurses and the respiratory therapists, you're your best defense against somebody doing something wrong.
Absolutely.
The more you know about your medications and the more you know about your health and how to do it, you're going to be safer, and this really has to be about safety for you. You go places and they just don't know exactly, but even though as much training as we do, there's always some agency nurse or float nurse that's put on the floor and may not know, and we really try to make sure that our patients are the most educated people about their disease and about their medications. And interruption in inhaled therapy can be a problem because you can have side effects of any prostacyclin being withdrawn. You can have a little rebound and get a little bit worse, so we try not to interrupt these therapies if we can help it.
What's that look like? What do you think it looks like getting a little worse if you have that rebound or if you miss a dose? Have you ever missed a dose? Other than when you hadn't put the medicine in? Wait, microphone. We'll wait for the microphone. Hang on 1 second. We'll get the microphone.
Oh, sorry, I'm going to give it to her and come.
We're going to make Brittany work. Thank you, Brittany.
There were a few days where I was only able to get 3 doses in because of whatever my schedule was for that day. And there were a couple of times where I actually stayed up till 2 in the morning so I could get that 4th dose in.
Oh, my goodness.
But then, I thought, I'm really defeating the whole
Right.
purpose here. So,
Don't ever do that again.
I didn't do that.
It's 2 little victories.
Right. But I want to come back to the potency issue. Are these prostacyclins drugs that need to accumulate in your body so that if, for example, you miss a dose and you need to go 6 hours before you do the next one, are you losing a lot of the effect of it?
That's a very, very important question that I'm going to interrupt for just a second to kind of give you a perspective. Flolan, one of the IV medications, has a 3 to 6 minute half-life, very, very short window. So when you're without it and it leaves your body, it's gone that quick in 3 to 6 minutes. The inhaled therapies are there longer. I'm not sure the half-life.
Tyvaso is about 4 hours, and the Ventavis or iloprost is about 20 to 25 minutes. So it's
So that
it's
means it's
longer
gone.
than the IV therapy, but still quite short. And
the
that's
thing
why
is
they have
what-
to be administered frequently.
Yeah, the
throughout
thing we measure, though, was those that are circulating drug. And remember, these are inhaled drugs, and we don't really measure the intracellular effects because these drugs do work inside the cells in the lungs and the blood vessels. And so we don't measure those effects. We know that an IV patient needs a certain high level to keep the effect going, and that goes away quickly. But for our inhaled drugs, there is an action in the blood vessels in the lung and in the cells, and we don't know how long that lasts. If we look at patients who've had a heart cath, where they look at the pressures and monitor them, the quick effects go away in about 20 minutes. But you may see the increase in walk stay for about 3 hours for Ventavis, and Tyvaso it's a little bit longer. Because some of the trials we did with these drugs, we would do we'd have a walk, we'd do a treatment, and we wait a certain period of time and walk again. And we could see an increase in the walk after a treatment, and it would last for about 4 hours, 6 hours with those drugs. And that's why I tell people, use it before you do some activity, because then you have a little more gas in your engine and you can go a little further. So that's a really important thing. And then you have in your mind, oh, I got better with that, and you'll use it again. But don't stay up till 2. Terrible.
Yeah, don't stay up to 2 and try not to miss doses, and that sounds redundant to say, that, everyone knows that, just like my colleague missing his antibiotics.
But it's a very hard thing to do because we start asking you to do this. I've had patients on Ventavis for 6 years. And if you can think about taking something 6 times a day for 6 years, it's hard. I mean, what we ask our patients to do, we already said we can't do. So we need to make sure that you see results from it, and we need to make sure that you have the best results, because this is a tough disease, and we care about you, but we can't do it for you, and so we have to work together in this. And your family's good in this, or your caregivers are, because they can remind you, and they can encourage you, and they can say, and they can point out, you did really well today because you were up and moving a little more, and I bet you took all your medicine. You can say yes.
So the medicines only work if they go into your body. That's what I always tell my patients. It doesn't do any good to be sitting in the pill box. It doesn't do any good to be sitting on the nightstand. The medicines only work if you take them, and it can sometimes be challenging, but it can make a difference in quality of life and quantity of life.
But also say if the patient doesn't see a result, they're not going to take it.
I really like your suggestion of taking it before you go to the Walmart or go to the store, because that gives you a really good positive reinforcement that you can associate you took the medication and now you're walking better, potentially. I was going to ask about the young man. Did you say you're on inhaled therapy or
No.
No? Oh, sorry.
He's on IV Remodulin. We were
Oh.
just curious. We had heard a little bit, but didn't know too much about him.
IV Remodulin, very good. For how long?
He's been on Remodulin since August of 2013, but he was on Flolan prior to that.
The thing about younger people, younger patients, there are no approved drugs. FDA has not approved any drugs for pediatric population. That doesn't mean we don't use them, and that doesn't mean they don't work, but studies are not usually done on that patient population, which is not fair, but so no, neither is life. So,
Can you tell the difference?
I'm sorry, go ahead.
Can you tell the difference in how you feel on the medication?
Between which ones?
Well, just in general, like before you went on.
When I didn't have the medications, it was really hard to do mainly anything, like going up and down stairs, trying to run with my friends, or any daily activities, just like maybe walking around the house or something like that. After I had my IV medications, it improved drastically. I was able to do all the stuff my friends could do, just not as well as them, of course, but
Sure.
all improved. My breathing went really well. I didn't have to be on oxygen.
That's
so-
excellent. That's excellent. And how old are you?
12.
That's wonderful. You've been on it for how long?
8 years, right?
Wow.
Oh.
8 years. He was
Yeah.
on Flolan from when he was 4 until he was 10. And then
Wow, good
about
for you.
About age 10, they switched him over to Remodulin.
Okay.
That's great.
Do we have other questions? Y'all questions are wonderful. I'm
She
so
had
glad
one
you're
more
asking.
question.
There are two back there.
There's a lot of evidence at the moment showing that dual therapy is probably the best way to manage PH. I'm from one of those countries, South Africa, where we only have one treatment available. So we only have sildenafil. And one of my big goals when I go back home is to try and lobby the government and to lobby our medical insurers to try and get another treatment available, at least one other one. From your experience, which one should I be lobbying for?
Oh gosh, that's a tough question.
I know. I can't lobby for them all, so.
I have a contact that I could give you. I had the opportunity to go to South Africa a couple of years ago with Dr. David Badish, who's at the University of Colorado.
Yes, yeah, I know
And
him.
did you hear that story?
With Jenna Lowe?
Yes.
Yes.
Yeah.
So are you familiar with her mom, Gabby?
Yes.
So Gabby is probably the single biggest change agent I've ever met in my life. And if one person doesn't believe they can make a difference, they need to meet Gabby, because she truly has changed the face of pulmonary hypertension in South Africa. Having said that, it's a tough question. Revadio's there. ERAs, what do you feel about ERAs in that environment? Because you have to have lab testing typically.
Lab testing is not really too much of a problem in the private sector. In the state sector, it's maybe a little bit more difficult.
For ease of convenience, ERAs are for the most part well tolerated and I think easier to access. The inhaled therapies may be a challenge, and you know, the certainly prostaglandins, prostacyclins have a major role in pulmonary hypertension. But if you had to start somewhere, I would probably start with ERAs and would probably get less resistance from that, assuming that there aren't patients who need IV prostacyclin.
I would
Well-
also, I don't want to,
Ambrisentan.
Yes, I would suggest ambrisentan.
Well, I would say this from my perspective. The big problem is the cost of the drugs. And right now, sildenafil is off patent. And so it's a lot cheaper. The cost of the drug went down tremendously. And the next pulmonary hypertension drug that's going to come off patent is Tracleer. And that'll be this year. So it is a drug, even though there's lab monitoring, there's more liver toxicity. From a cost standpoint, Tracleer would probably be the next drug, because unless you get a deal with one of the drug companies, you're going to pay, retail prices for it. So Tracleer is to come off next, and it's in this year. We don't know if there's another manufacturer right now.
Yeah, that's a good point.
But it will be. And I think, as physicians and nurse practitioners, we really want our patients to get the best therapy. And for you, I would want everybody to have the choice of IV, at least one ERA and one PD5 group. But it's a big country. You have a lot of health problems. You have a huge HIV population, and those drugs are very expensive too. And so if we really look at the big picture as a public health person, I'm not a public health person, but public health always says you use your money to reach the most people the most inexpensively. And I would say if you look at the data from the Ambition trial, which used 2 drugs right up front, but they used tadalafil and ambrisentan, which are 2 drugs that aren't off patent, but there are 2 classes of drugs that Tracleer and sildenafil would be in those classes. And we don't know if it would be the same results, but if I was a public health person, I'd say we ought to try those and see what we can do. And I think that, we want to reach as many people as we can, and I think oral therapies are the easiest that we can get, and those 2 would probably be the cheapest.
And I would get the Pulmonary Hypertension Association involved in helping if you haven't already, because
they will be. The only concern, why I absolutely agree in terms of the cost of Tracleer and it coming off label, I have a couple of concerns. You said one with lab monitoring wouldn't be an issue. There has been some data that has shown that Tracleer and Revatio don't really work as well together. That would be a little bit of a concern. And then secondly, with ERAs, that class of medication, women of childbearing potential have to be pregnancy tested and have to use 2 forms of birth control. So that's always a concern looking at the ERAs, because they can cause fetal toxicity, and even females of pregnancy-bearing potential, you can't break the pills, you shouldn't really be around the pills. So it's something to kind of keep in mind.
And tubal ligation is not a form of birth control. If you have a tubal ligation, you must use the barrier method too, because it's not by itself alone enough. We had a question in the back.
I'm already on combination oral therapy. What range of pressures is this medication appropriate for?
What are you on?
I'm on Letairis and Adcirca.
So there isn't a range in pressure that we typically use as a cutoff to decide as a trigger when should we add that 3rd medicine. I take a holistic approach, and I think most colleagues would agree that we take a holistic approach in looking at not only pressure, but lab data such as BNP levels that we measure, and then quality of life questionnaires, meaning what can you do and what causes you symptoms, and then get a functional assessment with a 6-minute walk distance, and how far can you walk and how limited are you by your symptoms. And if personally in my clinic, if patients aren't able to do what they want to do because of symptoms, then I use that as one of the main triggers to say we need to step up our therapy. Because pulmonary hypertension is a multifactorial disease. We have 14 medicines that target 3 main targeted pathways, but we know there's numerous dozens of other pathways that we haven't been able to target with FDA-approved drugs yet. And so it takes usually a recipe to tackle this disease.
We also know that all patients aren't the same. Some patients respond better to certain classes of drugs than others, and we don't understand why, but we do know that. The other thing is we want to see your day-to-day activities come back to almost normal, and we want to see the right side of your heart on your echo perform better, because we know that if the right side of your heart is performing well, you're going to do much better in the big picture of things. And so, I have patients whose symptoms are not so bad, but the right side of the heart doesn't look so good, so we can go ahead and try to convince them to take a little extra medicine or a different medicine. We want to see that you can do normal activities without being too breathless. And for my patients, we assess their functional class when they come in. And for women, I usually say, can you change the sheets on the bed without stopping because of shortness of breath? And if they can, that's functional class 2, and if they can, it's functional class 3. For men, there's no way to figure it out because they don't do anything at all, so it's really impossible. So
have them change the sheets.
Yeah, good luck on that one.
Any other questions at this point?
So let's sum up. We have prostacyclins, which are inhaled drugs, we think are really good for patients because they get the drug right to the pulmonary vessels where they work. They can improve your exercise capacity, they can improve your cardiac output, and they're really a pain to take.
I think they're good options, although they can be cumbersome. There is a role for inhaled therapies, specifically for patients who aren't quite sick enough to require IV therapies or don't want to be on IV therapies as a potential other option to get prostacyclin into the body. They can be very expensive. There can be side effects, but experience has demonstrated that the side effects are often much less and better tolerated than the IV therapies.
I would have to agree with my colleagues that there's a place at this point in time for for inhaled therapies, but work with your providers, listen to their advice and suggestions, but be your own advocate. If the inhaled medications aren't working for you or you don't feel like they're working, then have an open and honest conversation about what the next step might be. It doesn't mean that if you go into your provider with an expectation, it doesn't mean that it will happen, but open the dialogue.
I would echo that. Communication is the most important thing you can have with the people who take care of you.
Not only your physicians, your nurse practitioners, your specialty pharmacy, and your family. Those things need to be open and don't hold back. Okay, tell them really what's going on. My patients come in and say, "Oh, I'm fine," and their family says, "No, you're not. Tell them the truth." And so really, we don't want to bother you. No, it's a bother if you don't tell me what's going on, because we can solve problems a whole lot easier if they're little problems as opposed to really big problems.
And sometimes it's scary. If you think about it as a patient, you go to your provider and you think, oh, if I tell them truthfully what's going on, does it mean I'm worse? What's really behind it? So fear drives a lot of that. But I think if you put it out in the open, like the doctor stated, if you put it out there, sometimes it's much easier to tackle the small instead of letting it get out of control.
Any other questions, guys? Well, thanks for coming out to the last session in the last hour of the last day. Y'all are great.
Yes.
We really appreciate you.
Thank you so much.